One sec. So, quick question to get everybody warmed up. Tell us which state you're from. I don't want to know your city, just your state. Just tell us in the text chat which state you're from. Any answers coming? Yeah, I see lots of answers coming. This is really lovely. We have people from Ohio, Pennsylvania, Florida, New Hampshire. Wonderful, wonderful, wonderful. And let's go further. Next question. When you think of exercise, now we've got to think a bit, okay? When you think of exercise, what is the first thought or idea that comes to your mind? Use just any one word, to describe it. When I think of exercise, just to get you all started, I think of pain. I know how much my body is going to hurt. So I think of pain. What comes to your mind when you think of exercise? Just use the text chat to write your idea, health, endorphins. Great. I'm the only one who's thinking about pain. Rejuvenating, invigoration, wow, all very positive stuff. Strength, stress relief. I'm not surprised that Bob says stress relief and Raveen says relief after pain. Great. Sam says hard and Neha says energy. Good. Okay, wonderful. There's a lot of variety in the responses and we'll get started. Keep these coming, keep these coming. So before we really dive into the session, I just want to remind you all that this is going to be really interactive. Feel free to keep sharing your ideas and your questions in the text chat. So your window to us is the text chat. Just feel free to keep talking. Let's have that conversation going. And we are also recording this session. So I hope we have everyone's consent for that. And there are some more interesting answers coming: dopamine, relaxing and fun, pain to arthritic. Yeah. And I think now everybody stopped responding, but that's good. We got a whole lot of answers. And I'm going to go further into the session and now introduce, one sec, all our esteemed panelists. So we'll start with Dr. Robert Salis. We call him Bob. He's our moderator for this. And so after the introductions, I'll hand over the session to him. He's Director of Sports Medicine Fellowship at Kaiser. And I'd asked him, what is his favorite form of exercise? And he shared that it's jogging and pickleball. That's his new favorite sport. And then I want you all to know that Mike is also one of our panelists. He's the CEO of Smart Health Clubs. And he's also the ex-CEO of the Claremont Club, a very large health club in Los Angeles. And his favorite form of exercise is cardio 6 days a week and strength training a couple of times a week. And then we have Dr. Karen Wonders, and she's the founder, CEO of Maple Tree Cancer Alliance. Her favorite is running and lifting weights. Now let's go to Dr. Jay Harness. He likes to, he's the breast cancer surgeon, and he likes to do aerobic and strength training 5 days a week at a fitness center. Very, very correct, very, very proper. And Dr. Liz Joy, she's Medical Director, Community Health, Intermountain Healthcare. And she loves, this is a big list, everybody just keep waiting: hiking, biking, weight training, yoga, downhill skiing. That's my dream list. I'm going to get there one day. And then we have Dr. Catherine, and she is an Associate Director at Catchment Area Research and leader UPMC Moving Through Cancer Program. Her favorites are jogging, very solid. Nico Pronk, PhD, he's President, Health Partners Institute and Chief Science Officer, Health Partner. Snowshoeing, and I don't even know if I got that right, snowshoeing. And then we have Mark Jesse. He likes to walk with his wife and play sports with his sons, which is basketball and baseball. And he's Vice President and Chief Medical Officer, Texas Plan, Blue Cross and Blue Shield. So I've introduced everyone now, and I'm going to hand this over to Bob. He's going to lead this panel discussion, moderate it, and over to you, Bob.
Thank you, Ruchika. Well, I love the panel we've got together today. I appreciate everybody for coming. And sort of the genesis of this, and I don't know, Ruchika, you put up those poll questions. Did you want to ask those, or?
Yeah. We'll do that. Let's do that first. Ajay, go ahead. Yeah.
So I think these are going to be audience poll questions. Is that the idea?
Yeah, these are audience poll questions. Okay. So the first question is, do you believe your club should serve your community by offering exercise programs for cancer patients? Yes or no?
So for the health club folks in the audience.
Mm-hmm.
Okay.
Are some numbers coming in?
Yeah, we've got plenty of numbers coming in. About 18, 19 people say yes to that.
Perfect. Let's go to the next poll question. Do you believe your club should serve your community by offering exercise programs for cancer patients? Do you think cancer patients can benefit from exercise during or after the treatment? Yes or no?
We got a lot more enthusiastic in terms of responses here. We've got about 25 people saying yes to that.
Definitely. Okay, so we hand it over to Bob. There you go.
All right, great. So we've confirmed we're preaching to the choir here. That's a good thing. You know, the topic today is breast cancer. I think it's one that we don't as often think about for exercise therapy. And, you know, Katie has done an amazing job from her term as ACSM president, doing the research and really kind of pushing this to the forefront. But I think we could substitute a lot of different diseases. And the panel here are people I really respect that I think are thought leaders. And the idea for this panel was to let's just start with the science around physical activity in cancer, particularly breast cancer, and then move through, you know, what can be done about it. Would we prescribe it as physicians? Is it in the guidelines? And then taking it on to what programs could be available, how could it work with merging health clubs to sort of be the place where we fulfill that exercise prescription, and then ending with, why isn't it being done? Why aren't patients getting it? Why isn't it being covered by health insurance? As a family medicine physician, it is just astounds me, the power of pharma to get things paid for. And when you compare the relative benefit versus the cost, what they are able to get insurances to pay for and health plans to pay for, why is there such a disconnect with exercise when we've demonstrated these tremendous benefits? So with the idea of the topic is breast cancer, I want to start with Katie, you know, an esteemed researcher on the health benefits of physical activity when it comes to breast cancer. Katie, can you just take us through an overview of the research, that much of it done by you, but done by others? And what is the status of the research on the benefits of exercise for breast cancer patients, both during and after treatment, actually, and even before treatment? Maybe you could just kind of summarize that for us. What is the state of the evidence there?
Absolutely, Bob. Thank you very much. And thanks for the invitation to join this esteemed panel. I'm really interested to hear what the other panelists are going to say too. I had the great honor of leading the American College of Sports Medicine International Multidisciplinary Roundtable that was about this topic, about exercise and cancer in 2018. Bob was a member of the panel as representing family medicine on that panel. And we did a very thorough review of the evidence base. And in the setting of breast cancer in particular, we know that physical activity is associated with about a 10 to 20% reduction in the likelihood of ever being diagnosed with breast cancer. So there's a preventive effect. We know that breast cancer has physical activity has a strong effect on symptoms and side effects as women go through their breast cancer. That has been underscored not just by ACSM and American Society of Preventive Oncology and clinical oncology guidelines that tell us that we should be prescribing exercise for our patients as they go through their treatment. But most recently, the National Accreditation Program for Breast Centers has issued brand new standards and now requires that breast cancer patients be referred to exercise programming as they're going through their chemotherapy, as well as during the survivorship timeframe. There are a variety of different outcomes that we would be interested in as women are going through their treatment, fatigue being key among them, anxiety, depression, function. We improve body composition. We decrease chemotoxicities. There is some evidence that was led by Karen Wonders on this panel And then I got to jump onto as well that shows that we can reduce healthcare utilization in breast cancer patients who are active as they go through their treatment. In the survivorship timeframe, whopping effects on reduced risk of recurrence and death from breast cancer on the order of 40 to 50% for those who are most physically active compared to those who are sedentary. And so we have guidelines that are very dose specific. The evidence is not vague about how much exercise people need to be doing, and the amount they need to be doing is not as much as the people on this panel are telling you that they're doing. That's great news, because we don't have to get people to do marathons in order to see really strong benefits. But the amount that people need to do during their treatment is about 3 times a week of aerobic activity, twice weekly strength training, and the recommendations for prevention of recurrence are 150 to 300 minutes of aerobic exercise weekly and twice weekly strength training. So that's the evidence base for what we should be doing.
So Greg, take it from the scientist who's done most of the research. Clearly, the benefits are astounding. If you put it up against any of the current drugs we use, the chemotherapies, we've got a very strong evidence base. So I want to go next to Jay. You're a surgical oncologist for many years. Can you talk specifically about the guidelines for women with breast cancer? As a surgeon, what did the guidelines say in your field, and are these being followed? Is your sense? I'd really curious what you think, how often these guidelines are being followed with regards specifically to exercise.
Well, Bob, thanks so very much for having me on the panel. And the answer is not much. I mean, basically, when you think about it, we have so much science here, thanks to Katie and others. And I've often said to people, if we had this much science for a new surgical procedure, it would have been standard of care years ago. I think one of the big breakthroughs actually came last year when ASCO put out its guidelines on exercise. Just repeating, I've got them verbatim right here. Oncology providers, that means me as a surgeon, medical oncologist, radiation oncologist, should recommend regular aerobic and resistance exercise during active treatment with curative intent to mitigate side effects of cancer treatments. I think one of the barriers that we've got several barriers that we're going to talk about later, but one of the biggest barriers we've got is a physician education barrier. All of us as physicians know that exercise is beneficial. Very, very few of us are aware of the hard science that Katie has just outlined. So that's number one. Number two, often physicians say, well, gee, Mrs. Jones, here's a brochure. Why don't you head off and maybe join Livestrong or whatever, do something. And frankly, as Katie has reminded us time and time again, if patients are not involved in programs, they probably won't do it. In other words, brochure therapy doesn't work. And then finally, as we progress on with this panel, we want to talk about the reimbursement issues and why don't we have this? As you've already suggested, Bob, pharma has got too much dominance in this area, and we need to deal with that. So the only current standard, if you will, that we've got is the ASCO standard. What's coming is NAPBC, as Katie has outlined. I think that's going to have a real impact in the world of breast cancer. Thanks.
Great. Yeah, so I that frustrates me that physicians sort of use, well, I wasn't taught about it. So if you weren't taught about aromatase inhibitors and you're an oncologist and you weren't prescribing them, you know, what would happen? I mean, that clearly you'd be below the standard of care, but quite frankly, you'd be committing malpractice. I don't know how we stand for that lack of knowledge as an excuse for why it's not being done. You know, and I think also sometimes with physicians, there's just not an easy way for me to tell. I can tell my patients to go walk, but I need something more. And Karen, as somebody who's been in the fitness world, I'd love for you to talk about programs that we have out there, specifically some that you've worked on for breast cancer patients. That's really a soup to nuts, starting with your diagnosis. Talk us through what could be done. What is out there that could be offered to patients?
Sure. Yeah. Thank you. And thanks for inviting me to be on this panel. I run an organization called Maple Tree Cancer Alliance. And what we do is partner with hospitals and fitness centers across the country to provide our services. And basically what we do are individualized exercise training. So we work with all types of cancer, not just breast cancer patients, any stage, any age, anything. And when they're first referred to our program, usually it's in the middle of their treatment is when they come to us. Ideally, we would see them right at the time of diagnosis. This doesn't always happen. But when they're first referred to our program, we take them through a comprehensive fitness assessment, and we look at all components of fitness. So cardiovascular, muscular strength, endurance, flexibility, body composition, balance, posture, everything. And then based on that, we then create an individualized exercise prescription for them. And we really want to target here. And I think that it's important that any exercise program that someone with cancer is undergoing is going to specifically target those strengths and those weaknesses and the side effects that are brought on by cancer and its associated treatments. You know, if you're talking about breast cancer, you really need to be aware of signs that are related to lymphedema or corneal or, range of motion limitations that those patients may be experiencing, and understand how to address those in your fitness programming. And I think it's also important, there's fitness professionals on here. I think it's important that we as fitness professionals know our lane and understand where our skill set ends and where we need to then go to someone with a higher skill set, like physical therapy, occupational therapy, that sort of thing. And creating those referral pathways into those programs, I think is very, very important for the good of the patient. So when we're working with breast cancer, we specifically look at strengthening their upper body, increasing their range of motion, watching for complications. All of our exercise programming that we do is executed under the supervision of a certified exercise oncology trainer. And every 12 weeks, we're continually reassessing that patient, making program modifications and adjusting their program as necessary. And then, of course, that gives us data that we can then work with the scientific community to publish and to help further promote this field.
Thank you, Karen. So amazing. We've got programs, evidence-based, based on the scientific research and following the guidelines that are out there. I next want to go to Liz, as a longtime family medicine physician, someone who does a ton of women's health. I know you prescribe exercise for your patients with breast cancer, but I want you to talk maybe from the perspective of the everyday family medicine physician. Are they doing it, do you think? And what kind of results are they getting? And even speaking in terms of when you do prescribe it to your patients, do you think they do it?
Well, maybe I'll just start with the process. And I think that's always kind of a good framework. And the one that we recommend and utilize and teach to is this concept of SBIRT, or screening, brief intervention, and referral to treatment. And screening really starts, at least when I'm seeing a patient who has a breast cancer diagnosis or even a breast cancer history. I'll even say a breast cancer risk, which now encompasses, a significant population of women. It starts with the physical activity vital sign. We need to know, what they're currently doing in terms of their aerobic physical activity. The vital sign that we have integrated in our electronic health record doesn't specifically assess strength training, but hopefully it will at some point in the future. But that's a good start. That gives us, at least from their own words, what they're currently doing. Brief intervention is oftentimes, taking a little bit deeper dive in terms of, what are their goals for exercise. You might take a 5A's approach of understanding where are they? Are they in pre-contemplation or contemplation, preparation, action, or maintenance? I don't spend a whole lot of time talking about exercise for somebody who is regularly exercising. And I may have a very different conversation for somebody who is in kind of pre-contemplation. I use other evidence-based, and we recommend that people use other evidence-based approaches, whether it's 5A's or a behavior change framework, but to really, take an evidence-based approach to assessment. And then it's referral to treatment, which in this case is oftentimes connecting people to resources. And that's where it sometimes gets a little tricky. And I know we're going to talk more about that, but what are the resources that are covered by someone's insurance? What are resources that people will have to access through out-of-pocket costs? They may already be have access to resources that would meet the needs of their breast cancer prevention program, or addressing physical activity during the course of treatment, or within the context of survivorship. And that's I think for a family doctor, all of that is within our scope of practice. And it sounds like a lot, but it actually can be done really relatively quickly. And we have provided our physicians, with a kind of a care process model, to help them do that, and to also define for them, the resources that are available both within the healthcare system, are considered exercise benefits through our payer, and then connecting to community resources when those are available. So I'll stop there for now.
Great. Thanks, Liz. So that's a great backdrop. So we've got physicians in the office. There's some standardized recommendations that we ought to be doing for assessing, prescribing exercise, particularly in patients with breast cancer. We know, though, that this is a vulnerable population that has some limitations that we need to work around. And so I think it's imperative that I can send those patients to somebody who's got experience. And I want to next go to Mike Alpert. Mike, you've been previously CEO of the Claremont Club, and you had these amazing programs that I'm very familiar with for women with breast cancer. And so my thought is that I ought to be able to send these patients to a health club. Let's face it, today, most of my patients who belong to a health club, I'm not worried about. It's the ones who don't belong that I'm mostly concerned about. And I think this could be a viable option. Could you tell me about how it worked at the Claremont Club? And specifically from a business standpoint, were you able to sustain these programs to make them available in the community?
Well, yeah, thank you, Bob. And again, for me, this is a real honor to serve on this panel. So thanks for having me as well. The business model did work. We put over 1,300 women and their families through the program, and we saw a 37% conversion rate to full memberships at the club, which amounted to a little over $500,000 a year in additional gross revenue. We also were able to create meaning and purpose for both staff and members, which really led to lower attrition and longer length of membership. I don't think most people have any idea, thank goodness, of what a depressing diagnosis breast cancer is. And we got to see day after day after day the important role that the socialization had on their mental well-being. The women in the program had a support group. They made friends. They talked about and looked forward to Christmas parties and social events at the club. And they really became part of a community within a community. So I want to say that I really can't stress enough how important the social piece is to all of this. The important role that a health club or health clubs and community centers play, to begin with, they allow for scalability. And what I mean by that is the ability to help millions and millions and millions of women with breast cancer every year across the United States, not just 1,300 over a number of years. Yes, the clubs prosper financially, but much more importantly, they become a place where all people feel comfortable and welcome, and not just a place that fit people go to look better in a swimsuit. As an industry, we've talked for the past 3 years about the role that health clubs play in serving their communities, and that they should be considered essential businesses that should remain open just like medical facilities do. But clubs don't become essential for solely making fit people fitter. They become essential for keeping people healthier and for preventing and treating chronic illness, because what they have to offer is truly, I believe, the most powerful medicine we have today. Exercise is medicine, and it's time that it started to be treated as such.
Thank you, Mike. So we're talking about a horrible disease, the second most common cause of death in women, that we have research from the very basic level showing tremendous benefits of physical activity. It's in all of the guidelines. Family physicians prescribe it, or should be all assessing and prescribing it, not just in terms of breast cancer, but for all chronic disease. Health clubs, we have health clubs across the United States that really kind of need a new demographic, and it seems to make sense that this would be a great place to fill that prescription. And the programs that are out there that can be implemented in the health clubs. Why aren't we using them? So I next want to go to Nico. President at Health Partners, a chief science officer. You've been in the healthcare space, and I know you're a big believer in physical activity. I really want, from your perspective, why isn't this being done? And perhaps what can we do to change that? Why isn't it being prescribed like chemotherapy?
Well, thank you, Bob, and thanks for inviting me on this panel. This is great. Well, let me just start by saying that I'm the CSO for Health Partners, which is an integrated, not-for-profit, consumer-governed health system in the United States that provides both care and coverage. So we have to sort of think about the care delivery side as well as the health plan side at the same time. And so our members have an option of receiving their care in our own health system, but in fact, they can choose not to and go somewhere else, and the health plan would still cover their benefits that way. Now, that said, Health Partners actually does make exercise oncology programs available to its patients. The program is referred to as a cancer rehab, similar to cardiac rehab kind of approach. It's actually an order set available as an option in Epic, our electronic health system. That program is covered by Health Partners insurance. In fact, when it was introduced nearly 2 decades ago by our Park Nicollet clinics, it won an innovation award at the time. So I think for some, at some level, it was perhaps thinking, before the time had come, that all the evidence was available per se. But when we think about the provider side, most of our providers may encourage their patients to do that, but many do not. In fact, it's referred to less and less as a program. Non-referrals, in fact, appear to be the main reason for non-participation, which is similar case for cardiac rehab. So when I talk to our oncologists about this topic, they tell me things like, well, exercise during cancer treatment is definitely important, but it also is generally supported by evidence, particularly when you look at the most recent 2022 ASCO recommendations. But in the midst of all of this ongoing oncology treatment and chemotherapy, and dealing with 3 to 5 side effects during any given encounter, discussing life goals and end-of-life care, managing social and emotional issues that are going on top of everything else, it turns out exercise rarely makes the cut. And so most oncologists seem to support exercise, but they try to tailor their recommendations to the patient's abilities, time. Often this turns into referrals for exercise post-chemotherapy. And I think at the end of the day, the oncologists basically like good, clean, randomized controlled trial data, and there is still an uncertainty among them that exercise, that data exists for exercise. So I think more than anything, we need to make sure that we communicate the needs of that evidence that is available to all the oncologists. So that said, there are a couple of things that I think can really help with coverage decisions. In our system, one of the things that we look for is recognizing that we need to have a program that has an effect size. We need to have a program that is clearly defined in terms of its scope of services, because otherwise you cannot understand the cost of the program. We need to make sure that the program is scalable to at least reach the intended audience. And then finally, it needs to be sustainable at least long enough to get the maximum benefit out. then that is all related to the program design. But from an evaluation perspective, there are a couple of things we need to know as well. So first of all, we need to penetrate into this target audience, into this patient population of choice. Do they even know this program exists? So there needs to be marketing, communications, awareness. The program needs to be implemented in the sense that it needs to be accessible. It needs to have a good experience, you know, as people go through this. So implementation. People need to participate. So you can tell them it exists. You can operate the program, but did they enroll? Did they enroll to a degree where you can get benefit out? So participation. And then finally, effectiveness. And that is not an average effect across the population, but we want to know how many successes did we generate? At the individual level, was this program successful? Which means that you got to set your goals a priori. And so feeding those kinds of evaluation results iteratively back into the program design and let that, you know, drive in a sense the decision making on whether or not it's good risk for coverage. That makes a big difference in our system, and we look for those type of evidence as well. Very much real world oriented, in addition to having evidence from a research base.
Thank you, Nico. That's a great framework to try to think about as we move forward, trying to make sure that every patient has access to this. And again, I just find the distinctions so stark that pharma, you know, we know patients often don't take medications, and it seems to not be held to quite the same standard. And I next want to go to Mark Chassé. Mark is a longtime family medicine and sports medicine physician who has kind of gone into more administrative jobs, and he's got a big job with Blue Cross Blue Shield of Texas. He's their chief medical officer, a vice president of Blue Cross Blue Shield. Mark obviously understands the importance of exercise, but speaking from your role with Blue Cross Blue Shield, Mark, why is it, do you think that major insurances don't not only cover this, but actually mandate? You know, if we have a breast cancer patient, we know this is valuable. Why aren't the oncologists making sure it's prescribed? Why isn't it covered? I think in a lot of cases, we've obviously got some examples where it is covered, but I think the majority of health insurances don't pay for an exercise program with breast cancer patients. But Mark, could you speak to that and your thoughts?
Sure. Well, thanks, Bob, for having me. And I've been at Blue Cross Blue Shield here for 18 months. And one of the first things Bob came and reminded me about is, hey, man, we got to get this exercise thing still going. And so I appreciate him reaching out in regards to that. And, you know, when I was lucky enough to be tapped into this position, I told our plan president that, you know, the nutrition and exercise part of what needs to be done for our members was really a sword I was willing to die on so that we could push this a lot further. So with that in mind, I've been digging myself to try to figure out how can we, you know, turn the tide in regards to this. And so it's been an incredible journey to understand all the complexities, which are sometimes, I would say, man-made or regulatory made or our own education made, as some of the folks had talked before about barriers. I think as we move forward, one, it'd be good to get everybody's feedback if they do have some programs, maybe what you might have for your regional carrier, your carrier, what barriers you might have had and challenges, because those are always things that are good to know as we try to move this forward. But in general, what Dr. Pronk said before is the engagement piece is always very important. There might be some medical policy that we can put together. There's no doubt. And of course, when ASCO puts together consensus statements, a lot of times these medical policies that the managed care organizations use to for their insurance companies, they put those together in these medical policies to put together the plan on allowances for different types of programs. In the insurance industry, we also have groups, large groups, and some of them are a little bit more attuned to care management and other options, such as maybe an exercise program where you get a couple of visits with a credential provider. And maybe that credential provider could be someone that's credentialed in one of the activity centers so that they can get that done. Sometimes it's just the primary care doctor working in concert with the oncologist to put together a program. But we talked a lot about side effects and the weakness and the fatigue and the chemo brain of different things. And we know that the literature shows that these are all positives. So it makes sense to try to bundle some of that up. As some of the larger, as cancer sometimes gets, specialized in different areas, and it's holistically being done by the oncologist or the oncology team, I think it's important to think about different payment models to help with this, such as, a bundle payment or an episodic payment, so that there's that give and take of pay for performance in regards to them implementing these programs so that they can be paid ultimately on the outcomes, which is, I think, what we all want to look at here is we want to see the outcomes change. We want to encourage folks to do those outcomes because that's what's best for the patient. So I think it's definitely something that I'm working with our teams on just the medical policies. And then as we saw the oncology spend go higher during the COVID time period, I know that a lot of our groups and even internally, we're looking at what are some of the easy wins that we can do to help with this oncology spend. And this is the most cost-effective way to do that.
Great. Thanks, Mark. I think it's also very important to emphasize, again, we're talking today about breast cancer, but boy, we could put in any chronic disease into this and have the same sorts of discussion.
Absolutely.
Yeah, and we really, what we have is a poly pill. We know that patients who suffer from breast cancer are much more likely to suffer from other chronic diseases, heart disease, diabetes, hypertension, on and on and on. And this is, chemotherapy does nothing for those, but certainly putting the patients on an exercise programs help all of those chronic diseases that they're dealing with. And so with that kind of as a backdrop, I'd kind of like to get an opinion from Liz, from Jay, from Mark, from the physicians. What kind of obligation do we have as physicians to follow guidelines? And how do we push people to practice what the guidelines say? Any thoughts on that? And what are the ramifications of not following current guidelines?
Well, I'll just add, I think we have to make it easy for providers and care teams to do the right thing, right? And we need to leverage the entire care team in order to do that. We need to think about, what are we doing both at the point of care and what are we doing from a population health perspective? It will not be, and it cannot be successful if it's solely on the shoulders of the clinician, doing one-on-one patient care, for 20 minutes, and seeing 25 patients a day. It's not going to happen. Right. So I just think we need models of care that are better, that allow us to adhere to really high impact guidelines that are going to impact, a huge number of patients who have common chronic conditions. And, certainly breast cancer falls into that boat, along with heart disease is the #1 killer of people in the United States. And then all the precursor diseases like, diabetes and hypertension, osteoarthritis, et cetera.
So I'm going to jump in and add to that and say that I think, there's policy with a little p, which is the guidelines and the standards. And there's very little downside to not paying attention to those, many of them. But then there's policy with a big P, and who's actually paying for things. One of the things that I think we have to really look at is we can look backwards at examples of other programs that have gone through the process of going through policy with a big P, and how has it gone? And one of the things for us to really pay very close attention to as we proceed is not boxing ourselves in too much to how we're going to pay for this. I think that if we look at examples of the DPP, if we look at cardiac rehabilitation or PAD exercise, or even cancer rehabilitation that Nico has brought up, the proportion of patients who need these services who are actually getting them is actually quite small. And we have a lot of disparities in who's getting access to these programs. And so I think as we move forward and try to figure out how to press the easy button. We need to pay really close attention to examples from people who've come before us who've tried to do this and learn from them.
Great
I'll
comment.
just jump in for a second. You know, we talk about, Bob, that medicine is evidence-based, right? We all say we're practicing evidence-based medicine. And that evidence, as it piles up, becomes a standard of care. And when we talk from a medical legal perspective, for any of us to say we're practicing less than the standard of care, we would all be in trouble, wouldn't we? Huh? So my question, particularly to Nico and Mark, is how much more evidence do we need? How much more clinical trials do we need? How many more outcomes do we need to finally bring exercise up to the standard of adjunctive care that it is already in Australia and should be here in the United States? It just seems to me we have buckets of information and data and evidence to support it today being a standard of adjunctive care for all cancer patients.
That's a great question. Mark and Nico, love to hear your reaction.
Yeah, no, the evidence is
Yeah.
overwhelming. Yeah.
Yeah,
Well,
it's like-
we agree the evidence is overwhelming, but how do we
How do we get the response?
guys, to making it a standard of adjunct? No, we're talking about adjunctive care here, aren't we? What more do we have to do, Nico, to
Well-
make it a standard of adjunctive care?
Well, so I think your point is well taken. I think there is an evidence base available on this topic that basically says this works. The problem is that evidence base has not been translated very well into real world care. So for example, the framework I just went over, those 4 S's and that PIPE impact metric, we did a review on real world evidence available for the diabetes prevention program. We didn't find a single article that had that entire framework in it. So studies don't report on penetration into the target audience, implementation of those programs, participation in the program, and then how many people did actually experience a success. So when you come sort of to the real world implementation part, can you show that your program is working? So I think we need a lot more evidence that sort of shows that practice-based result that people are looking for. Just recently, the National Academies of Sciences and Engineering and Medicine did a report on the US Preventive Services Task Force insufficient evidence gaps to sort of respond to NIH requests and ARC requests to figure out how can we close those gaps. And if there is going to be new funding to support research, we don't need more randomized controlled trials. We need more pragmatic evaluations of programs in the real world that show these results. And I think that would go a long way to getting payers to understand that this is a good investment. And
I
think
see
that-
Katie is
it's
poised to
halftime.
jump into the middle of this, so I'm going to defer to Katie right now, okay? Katie?
I think there is an evidence base. I think that, in particular, I think that our colleagues to the north have done a tremendous job of looking at implementation science. And, I'm just finished reading a beautiful hub and spoke study that Nicole Koulos-Reed led that, shows that, you can actually improve the exercise oncology workforce, even in rural settings, and manage to reach like 80% of patients. So I think that evidence base is growing, Nico. I don't know that I want
I
to say
agree.
that it's done, but I think that evidence base is growing. And I think we have enough of it that I think that we should be acting. And we probably need more than anything is I keep having conversations to say, well, how do we get there? How do we, trying to talk to payers? I mean, I'm so delighted that we have a payer on the line here today. We need a demonstration project of sorts. I think where we are is that we need the DPP type trials. We need that to happen for exercise oncology.
Well, Karen,
Yeah.
can you address that? I think you've done some of that work. Can you talk about what you've done with your programs?
Yes, yeah. We've done a lot of work, not only looking at different ways that we can implement, but looking at the healthcare utilization and whether it works, if it's virtual versus inpatient studies. So I'd be happy to share those with the group. Ultimately, we have found that the patients who do exercise during their cancer treatment have lower healthcare utilization, particularly in the unplanned visits, which is one of the, I mean, I think it's like, Katie, you can correct me, but I think it's like half of cancer costs are unplanned healthcare visits, like ER visits and, for dehydration and that sort of thing. And so we do have that published data that we can certainly share.
So do we think there are missing, I go back to Nico and maybe Mark, are there missing studies that need to be done to show we have a program and it can be implemented, it can have these metrics that you measure it by, that it's successful, patients do it? Is there something in your mind that we're missing in terms of research that needs to be done?
I'll take that one. What Karen was talking about, it fits exactly. And I don't know how, Karen, how you've been with your regional carrier, or who you've been able to bring that to make that case. But those are the types of things that the payers want to be able to see as well.
Mm-hmm.
So
well,
yeah,
I wrote down to reach out to you after this.
Yeah, I think Nico gave a great framework. Nico, in your mind, is there a study that we need to do that's missing to take this sort of soup to nuts and have it be accepted?
Yeah, to me, it's closing that gap to the real world evidence. And I don't disagree with Katie that there is evidence emerging. And it's across a variety of chronic disease states and disease entities, but by and large, I think that's where the payers struggle. You've got a ton of randomized controlled trial data, but the translation part is so important, and that's a gap. So we need more pragmatic trials. Comparative effectiveness is a good idea. Implementation science, absolutely. And seeing a lot of the patient experience, the patient reported outcomes type of approaches, very important.
Great. Yeah. Funding always an issue with these. I really kind of feel maybe the health club industry can, a partnership there where they can help with to be able to pull these things off. But we got to, I think we're very close, and we just need these last few things to sort of make this happen. I'd like to shift gears and talk a little bit, with cancer patients. I have, for practicing medicine for so many years, really cringe at the quality of life versus the quantity of life. I think most of us will sacrifice quantity over, we'd want the quality. Can we talk a little bit about breast cancer and what you see? I'm throwing this out to everybody that cares for these patients, that have seen these programs work, what it does for quality of life versus not just quantity. I think a lot of times in chemotherapy, we ignore the quality of life. We know it negatively impacts quality of life, while the exercise programs have the exact opposite effect. Maybe talk about that, and how should we measure success with cancer treatments?
Karen, why don't you comment about that?
Yeah, I can talk to what we've done. We have data on about nearly 12,000 patients now who have been through our program pre and post. So when they come into the program and when they finish chemotherapy, and we have seen about 60% improvements in quality of life. And this is in people who are in chemotherapy. And I really believe, not only the exercising, I think, is so important, because this gives them something that they have control over. They have no control over how their body's going to respond to the chemotherapy or what type of medicine. I mean, they have very little control over the medicine that they're getting and that, but they can control getting up and going to the gym and exercising. And I think having that little bit of control helps to improve the self-efficacy and the quality of life. And I also think, and Mike Alpert touched on this whenever he was talking, the community that is built around these cancer survivors who are going through treatment together, who have completed treatment together, who have built this bond with their trainers. That's something that you just can't replicate and, you know, anywhere else, it's such a unique and special experience. And we have trainers that work one-on-one with their patients. And these trainers, we put them through empathy training, we put them through counseling, because they hear the brunt of what this patient is going through. If they're having marital problems, we know about it. If they're having job problems, we know about it. And it just gives the patients another ear, another person who can listen and, you know, maybe not judge them for what they're going through. And I think all together, all of that goes to improve their quality of life. I think that's why we see such high values and adherence rates. Our adherence rates are in the 90 percentile. So
A lot better than medication, I'll tell you that. At 90%.
yeah.
And Mike, maybe you could speak to what you saw at the Claremont Club, the effect. You know, I'm fascinated by this socialization. You know, a lot of the studies on exercise and chronic disease are done with patients either just walked and measuring with an accelerometer, or going to a lab where they walk on a treadmill or ride a stationary bike. And consistently, when we see programs that are done in a gym compared to the results where it's just done in an exercise lab, they get much better results. And I gotta believe it has to do with the socialization. Mike, maybe talk about that and how important that was in the breast cancer programs you were on. And we also had a comment in the chat about how did you fund those?
Well, let me address first how we funded it, because I think people want to know that. It was really not real hard. We worked with a local hospital, Pomona Valley Hospital Medical Center, with their cancer care center. We fundraised together. People paid for part of the program, and their foundation helped with part of it. So we built some of it into just operating expense. We felt that as far as doing well as a health club and making a profit, some of that profit should go back into the community. Now, measuring financial success can be many things. You know, seeing your membership attrition drop 8.5% in 1 year and have it attributed to the community outreach programs we ran was a little over $1,009,000 a year in additional revenue to the club. And that happened by mistake. That happened by mistake because our programs really weren't about money. They were about being a good community provider and helping to build and maintain healthy communities, which was part of our culture of running a successful health club. Then, as I said before, the conversion rate to full membership, even at a discount in dues, a deep discount in dues, added to an additional $500,000 of revenue a year that we didn't have before we started these programs. But the most important thing, it had an amazing emotional and spiritual effect on everybody that touched it, including staff members and people in the community that never even walked into the club. And those were real important things. So that's from the financial side. The benefit of having it in a health club or a community center is what I started my talk about and what you just hit on, Bob. The social interaction that takes place that keeps people accountable to others, that makes them want to come back, want them to do. And ours was the handoff after intervention, after treatment. This was when they were through with their cancer treatment. Where did they go for a continuum of care with something that gave them purpose and something to do? And our purpose, our treatment, I should say, was in groups of 11. So we were able to deliver the cost of the program at a fraction. And we were also able to show other club owners and operators that for less money than they charge for one-on-one personal training, we can offer that program at their club with full membership at their club with pretty much close to double the net margins that they would make from personal training. So
that's great. So with that as the backdrop, you know, maybe go to Nico, Mark, maybe even Liz to talk about, are there codes out there, CPT codes, that we could make a diagnosis? Are there reimbursements already available? Could a club get reimbursed for doing this kind of work if they had an evidence-based program? How would we go about achieving that?
Nico, you want to go first and I'll.
Yeah. Yeah, that's a great question. I just noticed Michael Benton in the chat kind of offered a similar thing. I think if an payer is interested in covering this, you can figure out the way to do it. My sense is that we should try to turn this into a value-based care opportunity, so that it fits with more of the direction that many of the payers are going in, looking at it from a value-based care perspective. I think that would be a great way to sort of coordinate this. But when it comes to outcomes, it gets a little bit more tricky because I don't think there is sort of a one single outcome kind of approach to this. There should be outcomes that are of value to the patient, to the provider, to the payer, and to the community. So some of this may have to be linked to hard endpoints of the disease state, but some of it may be more important from an experience perspective for the patient, and from the payer side, an affordability issue. So all of this sort of needs to come together somehow into the set of outcomes that you'd be looking for, and then pick the metrics that make sense.
Yeah. Mark, you have a comment?
I put in the box the value-based cancer. I got almost the very first day I was in my position, got asked to take a look at this, and they're always looking. I'm recruiting here. There's always looking for great panelists and great sessions. And I'm going to recommend to Bert that we have some of these great fine leaders come up to New York City in October and see if we can't have that discussion with some of the big folks, both payers, providers, some of the pharma, et cetera, to have these discussions, because I think that needs to be locked in as well. The other thing that I would talk about in our own organization, credentialing, as Nico said, we could figure that out. The folks that work at the health clubs or the community centers and stuff would need to be credentialed providers. We need to find a path forward for that so that they could get paid. That's if we do the fee for service. I really do feel like this is something that bundles up with a holistic part of the cancer part. This is a program that they offer. And you either look at outcomes at the end or some type of kicker payment for those that are engaged in that program, so that it makes it worthwhile for maybe a Texas Oncology to have that in their major market areas.
Great comments. Well, we're kind of running up against time here. This has been a great discussion. And again, as I mentioned in the introduction, we could be having this around heart disease, cancer. Liz mentioned in the chat, rheumatologic diseases, arthritis, on and on and on. I just think we have got to find a way forward. All of us here are passionate about the health benefits of physical activity, and we just don't understand when you take this strong evidence base, programs that work, doctors that will want to prescribe it, and how do we make it standard of care? It's already standard of care. How do we get everybody to follow that standard? So I want to thank everybody for being here. We've got maybe a minute or so for any last minute comments if anybody would like to make. Ruchika, do you have anything else to add here as we wind down?
I have one question that I want to, there was one question here. Yeah, what about robust multi-site clinical trials implementation science similar to the diabetes prevention program that led to CMS support? This question was from Robin.
Very much
Good question.
agree.
Funding. How do we fund those?
Exactly. We need a payer partner to make that
Any
happen.
thoughts on who could fund that potential? I mean, I think of the health club industry, they could gain, the fitness industry. It's
CMS.
interesting. What's that?
CMS would gain a lot. I mean,
Yeah.
we're talking about 50% of the population in the United States ends up at CMS. So if you want a payer to be part of this, I think that should be part of the equation.
And that could be as part of the innovation, CMS Innovation Center. In doing a little bit of reading before this, even though I'm on the commercial side in Texas, certainly the Medicare side with the Biden, moonshot stuff is looking at more of holistic ways in which Medicare can take care of these cancer patients.
Yeah.
Great.
And there's one last question. How much of the physician's resistance is about liability?
Yeah.
Liz,
so
what do you
we-
think about that?
Yeah, we didn't talk about this, but there's an issue. It's not just about the liability, it's about the triage. And this is why you need programs like Maple Tree Cancer, why you need to have programs in place, because physicians don't want to just refer their patients because they've got the 36-year-old who was playing tennis last week before their diagnosis and the 75-year-old who fell 3 times last week. And you can't just tell the physicians, send everybody to go exercise on their own. There's got to be some structure. That's why there needs to be a program and a place for somebody to go and a professional for them to be guided by. So I think that only by having those kinds of that kind of infrastructure in place do we get past the liability issue.
Great comment.
Yeah, and there's one last question. Let's take one last audience question before we end. This is Samantha, and the question is for Dr. Wonders. I heard from an employee from Maple Tree that by 2024, you and other exercise oncology programs will grow. Are you planning to have a club in other states such as New Jersey and the Tri-State area?
Yes. We are, yes, all the way around. We are serving out of, we're partnered with a cancer center in New York City, and we actually just signed intent to work with a health club in New Jersey, Pinnacle Health Club. So we're in the very, very beginning stages of that, but that has some ties to Robert Wood Johnson. And we're hoping that with that partnership, that will allow us to grow and to continue to grow in the New Jersey area.
Yeah, and Mike, how do we get these health clubs to be more interested? You know, how can we get them to be about health and less about club? I mean, I just think, I don't understand how we get their attention to really start treating cancer, start treating diabetes instead of just thinking about helping people look better in a bathing suit.
Well, I think that unfortunately, the COVID pandemic created some change that's going to happen. It certainly created a demand from the consumer for the digital or hybrid delivery of fitness and wellness solutions. And I think health clubs understand that. I think they're right on the brink now of understanding that there's a major paradigm shift that's going to take place in healthcare. And that paradigm shift is our responsibility to keep people healthier.
Yeah, I think there's a big role to play there.
So I think the timing's perfect right now. That's where I'm going.
Bob, I think what we're all about is improving our cancer patients' health span. And I like us to be focused on their health spans, and the data really supports that. We just now have to have greater and greater implementation.
Yeah. And I just feel like that the drugs get held to a different standard. There's no, what's the ROI on a chemotherapy agent? And you know, we don't really ask those hard questions of lifespan, of quality of lifespan. You know, there's not that expectation that it helps patients feel better, they enjoy it, they have this great experience. You know, there's nothing like that. It's just a very stark measure of how many years more did you, or months more did you survive? And
Bob, Bob, can I say one thing? I can tell you in my 31 years, 32 years in the health club industry, the programs we ran at the Claremont Club were the only programs in my business career that never got one negative comment. And we did exit interviews on every single person that went through these programs, including children and young adults. We worked in conjunction with City of Hope and Kaiser, as you know, on some medical research studies of these programs. People don't understand the impact that a 7-year-old with a bandana on her head has when they run up and hug you and say, thank you for this program, for having me here. I think that's what health clubs are all about, and that's where they're going to go.
Great. Jay, did you have a comment?
I have to unmute, sorry. No, well, first of all, Bob, I want to thank you for a terrific leadership on this panel. I thought it really flowed beautifully. I thought the input from everybody was really spot on. then we need to move on from this. But let us stay focused on our patients' health span. Thank you for the privilege of being here today. Thank you very much.
Thank you, Jay. Well, with that, I think we're a little bit over, but I really enjoyed the discussion. I hope this is the first of many. I just think we've got to really push to change the way that healthcare is done in this country. And we've got to have a bigger focus on health. And I think around physical activity is a great place to start. So thanks, everybody. Thanks for all the panel. And thanks for those of you in the audience that attended. Thanks for the great questions and feedback. And stay tuned. I hope this is the first of many discussions about how do we change this paradigm.
Thank you
Thanks,
all.
Bob. Thanks, everyone. Bye.
Thanks, Bob.
Bye.
Okay.